Good morning. I'm Jane Jordan and I'm going to cover the first session today, and that's going to look at changes to the core funding for GP practices and also changes to funding for PCN. So we'll start off with the changes to the core funding, first of all looking at GMS contracts, and you'll see from the screen that there's an increase in the global sum rate from £96.78 per weighted patient to £99.70, and that's an overall increase of 3%. There's also an overall increase in the out of hours opt-out charge of 3% as well, but actually that just ties in with the global sum uplift, and the out of hours charge remains at 4.74% of the global sum. This is effectively the pay rise for GP practices. There are minimum changes to other funding, and you'll see as we go through a bit later on that actually most of the new funding is being filtered through the primary care networks. Looking at your statements that you've received so far, you will already have had a pay increase in April 2022 based on these figures. So each practice should be able to assess how this will impact on them over the course of the year. I mentioned that this was the contract change for GMS practices, but of course PMS practices are now paid on the same basis. So PMS practices will also see a 3% increase in their funding this year as well. And if you are an APMS practice paid on the same basis as a GMS practice, your monthly payment should also go up by the same amount. And the reason that the funding is the same across GMS and PMS contracts this year is that there's now no longer any MPIG or PMS premium funding. So regardless of whether you're a GMS practice or a PMS practice, you're now effectively all paid on the same rate. Looking now at QOF, you'll see that there's a rise in the amount payable per QOF point from £201 to £207. So that looks as if on the face of it, you're getting a 3.18% increase. So that looks really positive. But actually, it's not really an increase at all, because the average population on which the QOF calculation is based has also gone up by 3.18%. So that means if your list size has stayed the same, actually your funding will be exactly the same. So in real terms, there's no actual change in the total funding for QOF. In previous years, there has been an increase in QOF just because the number of points available has increased. So the maximum points available in 2021 was 567, and that increased to 635 in 21-22. But you'll see on this slide that there's actually no increase in the points for 22-23. So overall, although on the face of it, it looks as if there's a good pay increase for QOF, there's actually no change. And we all know, of course, that there has been some protection for QOF as a result of COVID over the past couple of years, but that protection effectively finished on the 31st of March 22. So we are expecting for the whole of 22-23 that QOF will be payable on actual performance. And that's regardless of the fact that actually most GP practices are still overwhelmed trying to deal with the backlog within the NHS as a result of COVID. So actually for GP practices, the impact of COVID is still ongoing. It didn't suddenly stop on the 31st of March 2022. I mentioned the increase in the QOF points, which happened for the 22 year, and that came about mainly because of recycling of childhood immunisation funding. So prior to March 21, we had the quarterly targets for childhood immunisations and preschool boosters, and effectively they stopped at March 21 and were replaced by the 6-in-1 vaccine, where practices were paid a flat rate of £10 and 6p per vaccine given. Now, for most practices, that's resulted in quite a big decrease in their enhanced service income, but this was meant to be compensated for by 54 points being added to QOF in 21-22. The difficulty with that is that most practices are finding it very difficult to achieve the targets within QOF. So overall, there are 54 points, and for an average practice, and when we talk about an average practice, we're looking at 11,300 patients. That extra QOF funding would be equivalent to around £11,200. The targets for this, though, are quite high. So there are effectively 3 targets within there. There's an 8-month-old target, which is for diphtheria, tetanus, and pertussis. There are 3 points available within that if you meet the 90% target, but that increases to 18 points if you meet a 95% target. So there's quite a big difference between a 90% and a 95% target. There's also a target for 18 months old MMR. And again, quite a big difference in the points available. So 7 points if you meet a 90% threshold, but 18 points if you can meet a 95% threshold. And then the final area within QOF for childhood IMS is the 5-year-old targets. 7 points for meeting an 87% target in that area, rising to 18 points for 95% target. So that's something that we're going to see the effect of probably within the QOF achievement payments that are coming through due in June 22. And we'll just have to wait and see what happens about that. But from feedback we've had, it seems a lot of practices are struggling with this. And you will probably have seen a lot in the GP press about this as well. So those of you that have been on our courses before will probably be familiar with the next slide, which is how does this actually impact on individual practices? So we know effectively the only real increase is in the global sum. And if we base that on a weighted list size of 11,300 awaited patients, you'll see the global sum increase from 1,093,000 to 1,126,000. There will be a small increase in the out of hours opt-out because that remains at 4.74% of the global sum. So overall, that would mean an increase in the net core income from 1,041,000 to 1,073,000. So that's an overall increase of 31,429. That sounds fine, but is that really enough to cover your rising costs if that's all you're going to get as a pay rise this year? Effectively, it was intended that this pay increase should allow for a 2% increase in staff salaries. But that doesn't seem to really take into account the rise in the national minimum wage and the increase in the health and social care levy, which effectively means a rise in your employer national insurance of 1.25%. So 31,000 may seem like a lot of money, but I suspect it's not going to be enough for many to cover the staff pay increases, and certainly not enough to cover increases in other costs. Jo will be looking a little bit later in terms of what pressures there are likely to be on practices for the year ahead. In real terms, there is a slight adjustment to the global sum income because each practice will be paid a temporary residence figure within the global sum as well. I haven't included that on this slide because that is unique to each individual practice. The temporary residence figure is actually fixed in 2004 based on your performance prior to that, and it hasn't changed since. It hasn't increased for inflation or increased for any changes in the practice circumstances. So there's nothing you can do about that. That's just a fixed amount. So some practices will receive minimal amounts for temporary residence. Other practices, perhaps if they're in tourist areas, will receive higher amounts, but there's nothing you can do to change that. So that's it in terms of funding. The reason that we use a figure of 11,300 weighted patients is because that's the average from the benchmarking for Lentils clients. So we act for nearly 200 GP practices, and each year we compile benchmarking information from their accounts. The average list size is 11,300 weighted patients. So obviously if you were a practice of say 5,150, your increase is likely to be half the amount shown on the screen. Moving on now to extended hours. So this is an area that's caused a lot of controversy recently. We were expecting extended hours to change, and it's been delayed because of COVID, but we're finally going to see changes coming into play from October 2022. So currently there's £1.44 payable to individual practices as their share of extended hours income. This actually goes to the PCN initially and is then normally passed back to the practices. There's also behind the scenes a further £6 which goes to the CCG, and they will use that for extended access services. And again, in certain areas that may also be passed back to the practices. It depends how the CCG provide the services at the moment. From October 2022, all of that income will be going to the CCG to enable them to provide extended access services under the new scheme. So effectively, for the average practice of 11,300 patients, the extended hours income currently is worth about £16,000 per year. So within the 22-23 year, that average practice would expect to receive £8,000 rather than £16,000. And of course, some of this income may go back to the individual practices, but it depends how the CCG organises themselves. So although it sounds like a horrendous issue, some practices actually from a financial point of view may not find that they're any worse off. So what are the requirements in terms of providing the extended access service? Well, initially, the first thing the PCN needs to do is to submit a plan to the CCG, setting out how they are going to deliver the extended access service. That needs to be done by the 31st of July 2022. Part of the extended access service is that certain hours need to be covered within it, and those are 6:30 p.m. to 8 p.m. on weekdays and 9 a.m. to 5 p.m. on Saturdays. And I think it's the issue of the Saturdays cover that is providing most cause for concern. Within those core hours, the PCN needs to provide 60 minutes per week per 1,000 patients. And the 1,000 patients is based on the waited list size. The PCN can offer routine services within those network hours. So it could be used, for example, as part of covering the flu clinics. And the PCN can offer different hours to those or on top of those core hours if it's been agreed with the CCG that there is patient need for that. Now, does seem to be some issue over GP involvement within these core hours. There certainly needs to be GP cover throughout the core hours, but whether that needs to be face-to-face or remotely remains to be seen. Within the initial wording, it looks as if GPs need to be involved, but don't necessarily need to be delivering face-to-face consultations within those hours. But I understand there have been recent changes to that, and we'll wait to see what actually happens. The PCN could, of course, subcontract the work for the extended access. But then there wouldn't be an opportunity to actually pass some of the funding on to practices. And if there are appointments within those network hours which haven't been filled, then the PCN is required to pass those appointments back to NHS 111. Now, the initial gut feeling from this was that some practices were looking at coming out of the PCN because of these requirements. We had quite a few clients that contacted us regarding this, asking what the financial implications would be. I think that was just a jerk reaction at the time, and probably most practices have reconsidered. But longer term, I think if practices are looking at coming out of the PCN, it's not just an issue around extended access. They need to consider the longer term future in terms of other funding that is going through the PCN and whether they will be losing out on that. So what does this mean practically in terms of the extended access service that needs to be provided? Well, I mentioned the the requirement to provide appointments per 1,000 patients. If we look at the average PCN with a weighted population of 50,000 patients, that would equate to 50 hours of appointments within those network core hours over the course of a week. So practices will need to work together to ensure that they deliver that. It doesn't mean your individual practice has to deliver all of those appointments. It will need to be shared out between the practices within the PCN. So we'll move on now to look at changes to vaccinations and immunisations. And there's not really much that's actually happening in the year ahead on this. The rate for vaccinations and immunisations has remained at £10.06 per vaccine since 2018. So what that means is, in line with a lot of other funding, is there's actually been a pay cut in terms of this because it hasn't kept up with inflation. If the rate had been adjusted for inflation, you would be looking at a rate of around £11.24 per vaccine in the current year. So that shows effectively the pay cut that's being implemented by not increasing the vaccine rate. So we've now got used to the 6-in-1 vaccine new system, replacing the quarterly targets for childhood immunisations and preschool boosters. That's been with us for just over a year. But please remember, with that, although the old 90% and 70% targets have finished, there is still an 80% target that applies to the 6-in-1 vaccine income. If practices don't manage to meet that target, then half of the money will be clawed back. So that means effectively practices would only be paid £5.03 per vaccine instead of £10.06. So there is still need within the childhood IMS to actually monitor the targets. And obviously you'll be monitoring them as part of the QOF as well. So a couple of minor changes to the vaccine schedules. So HPV for most patients will reduce from 3 to 2 doses. I wouldn't expect that to have a significant impact on most practices, as HPV is mainly delivered through schools in any case. The MMR catch-up scheme for 10 and 11-year-olds has now finished, and the freshest meningitis scheme has also now finished as well. All practices will be required to take part in one childhood immunisations catch-up campaign in the 22-23 year. There are changes to the flu vaccine this year as well, which will probably mean that most practices will see a dip in their flu vaccination income. So the changes really affect the patients who will be included within the scheme. So assuming there are no underlying conditions, age 50 to 64-year-olds will now be excluded, and age 11 to 15-year-old children will also be excluded. And obviously, in terms of the flu vaccine, there's still continued pressure for patients getting the vaccine through pharmacies, which means that practices then lose out. And if patients aren't being given the flu vaccine through practices, not only does the practice lose out on the £10.06 vaccination fee, but they also lose out in terms of the profit margin made on the flu vaccine itself. So we are expecting a reduction in flu vaccines, but we have seen for most practices an increase in the past couple of years. What's happening with other funding? Well, there was included within the global sum for the past couple of years £20 million for subject access requests, and we were expecting this to be withdrawn for 22-23, but it is still in there. So that funding will still continue and is part of the global sum uplift. The weight management DES, which started in July 2021, was expected to only last for a year, but that is actually continuing again for 22-23. The slight change to that is that you need a patient's permission now to refer them, which I find it hard to believe you wouldn't have got the patient's permission in the first place, but that's been added to the rules. So that will continue for a further year, and the rate will be £11.50 per referral. There's a couple of other things, just minor tweaks. The requirement to respond to access to health records for deceased patients has been changed so that you don't need to print and send hard copies to PCSE any longer. And that we are expecting there to be further clarification on patient registrations with a move to this doing more digitally, so patients don't need to come in with hard copy records. There are also some changes to online appointment bookings, just a bit of a changing in the terms on that. It was felt that the wording was previously a little bit vague. Practices were required to offer 25% of online bookings for appointments previously. Now that's apparently got to be available for all appointments that don't require triage. So all appointments without triage need to be available to book online or still through phone and face-to-face, but there needs to be an online option for those appointments. And again, we're expecting further clarification on the detail of that later. You may be aware with the GMS contracts that effectively there was a 5-year plan for that, and that 5-year deal will end in 23-24. So we're now in year 4 out of the 5-year plan. There is an expectation, therefore, at the end of the 24 year that the contract would be reviewed and changed at that point. With the local issues with negotiations of changes to the contract, however, it would not be, it may be that actually nothing happens in terms of the contract. And if we get to 2024 and there hasn't been anything happening, the intention is that the contract will just be rolled over in its current form. So hopefully there will be some negotiation and we will get some useful changes coming through. But if not, then we are expecting there to be a 2.7% increase in the global sum next year, as set out in the 5-year plan, and then the contract should roll across for the following year. What this does imply, though, is that PCNs are probably here to stay. So PCNs were a core part of that 5-year plan. And if there is no change to the GMS contract and it does roll across, that presumably means that PCNs will continue as well. And actually, with the amount of funding that's being put through PCNs, it would be difficult to see how they could actually be unravelled at this stage. We often get asked from PMS practices whether they should actually revert to a GMS contract, particularly now as the funding is basically exactly the same. I think looking at our clients, we've probably got about 1/3 of our clients that are on PMS contracts, and the remainder are on GMS, with a couple with APMS contracts. And there may be advantages to moving across to a GMS contract, mainly because the GMS contract can't be ended unless something significant goes wrong. But a PMS contract can be ended by giving 6 months notice. So that's the main reason why you might want to move from a PMS to a GMS contract. Things to consider, though, if you did that, were that for salaried GPs, if you have a GMS contract, they need to have terms at least as favourable as the BMA standard contract. And also GMS practices get paid later in the month than PMS practices. So that could cause an issue in terms of timing of payments of salaries, etc., if your main contract income for the month hadn't gone in by the time that your salaries need to go out. So that's really all the changes to the core contract for this year ahead. I'm going to now move on to looking at PCN income and how that's changing. And actually, for most areas within the PCN income, there's not a massive amount of change. And you'll see, I've put on the slide amounts that are payable per patient, and you will see that some are paid by weighted patients and some are paid by registered patient. For many practices, that won't make a massive difference. But for some practices, such as perhaps those that are a university practice, their weighted list size will be significantly less than their registered list size. So that can have an impact on those. Sorry, I'll just move the slides back. So going down each core element of the PCN funding, we have the participation funding of £1.76.1 per patient. And that has been the same since PCNs came into being. So this is the 3rd year of payment at this rate. And this is another example really of fiscal drag where you're not being given a pay increase. So effectively it's a pay cut because of inflation. For the average practice, looking at Lentils benchmarking, the participation income provides them with around £20,000 per year in income. Looking at the core funding, this is another area that has seen no change since the introduction of PCNs. So we are now in the third year at £1.50 per registered patient. And for a PCN with a list size of 50,000, that would equate to income over the course of a year of 75,000. Clinical director income has increased a little bit. In the initial year, that was 72.2 pence per patient, and then that increased to 73.6 pence in the 21-22 year. So for a £50,000 PCN practice, that would equate to income of nearly £37,000. Care home income is staying the same at £120 per bed. This started in October 2020, so we shouldn't see any significant change for 22-23 year in terms of the care home. Additional roles reimbursement. Now, this is where the funding has been massively ramped up. In the first year of the PCN, the funding was only £7 a patient, and then we saw it rise to £12 last year, and then it's up to nearly £17 per patient in the 22-23 year. There's of course no profit from this because the R's reimbursement matches the cost, but it does give the PCN opportunity to employ more staff, which in turn can help out practices and hopefully relieve the workload at individual practices. For 50,000 patients in a PCN, this equates to funding of 842,000 if it's used in full. So that is a massive amount of income that's now coming into the PCNs, and it does need to be managed carefully. There's new income this year for PCN stroke leadership management, and that's going to be 70 pence per patient. So for a 50,000 patient practice, that's going to be equivalent to 35,000. Now that is new income this year, and it's up to the clinical directors to decide how best to spend that money. But it is a big chunk of money new that's coming in new to PCNs. And extended hours, we've already mentioned, effectively that's going to be £7.46 per patient from October. So for the whole year, that would be effectively £3.73 for this first year. For 50,000 patients, over the course of a whole year, that's going to be 373,000. But for the first year, it's going to be 186,000 for that 6-month period. So if we're looking at a PCN with 50,000 patients that is maximising its ARRS reimbursement, that's going to be income coming into the PCN of 1.2 million in the 22-23 year. So that's a significant amount of funding that's now being fed through the PCN. And looking ahead, it only looks as if it's going to be getting bigger. Looking at the ARRS funding, that has increased this year. So overall, the total funding for that has increased by 280 million. And the main area where that has increased this year is with mental health practitioners. So previously, a 50,000 PCN could have one adult and one child mental health practitioner, and they are now allowed to have 2 of each. Half of this is funded through the PCN and half of it is funded by community health. And there remain 15 roles that ARRS funding is available for. I won't go through each of them individually this year, but I'm sure you're all aware of things like the clinical pharmacist, community paramedics, etc. Impact and investment funds. Now, this is an area where significant amounts of money are now being fed through the PCNs. So there was a bit of a delay in getting this off the ground due to COVID, but effectively the IIS scheme started in 21-22. And in that year, there was a maximum of 666 points available at £200 each. So for a 50,000 PCN, that would be equivalent to 133,000 of funding. That's effectively being nearly doubled in the 22-23 year. So maximum points will go up to 1,153 at £200 per point, still equivalent to 230,000 of funding for PCNs. Think of this kind of as a bit like a QOF, but on a PCN level. So the £200 per point is based on average prevalence and average list size. As for QOF, adjustments will be made for prevalence and list size. And any income from this, the PCN must commit to investing in primary care. So it must go into the workforce, additional primary care services, or it can be used for things like supporting practices, buying equipment, and for building projects, that sort of thing. So lots of income available through that. The IIF is effectively split into 3 different areas. And there's a 97-page document detailing each area, which goes on a bit, but there is actually a summary sheet that you can get for that. So if you are interested, there is a kind of 1-page summary which actually looks in further detail at each area. So the areas are prevention and tackling of healthcare inequalities. That mainly covers things like flu vaccinations, learning disability health checks, ethnicity recording, CVD prevention. And then we've got providing high quality care. So that covers things like patients being referred to social prescribers, enhanced healthcare for care home patients, cancer access, medication reviews, a few other bits within there. Sustainable NHS, so that's all about being environmentally friendly, and that's looking at things like inhalers. Some of the above indicators were in place for 21-22 and covered a 2-year period, but because of COVID, if that was the case, then any achievement on that will be based on the position from 1st of April 2022 onwards. There is planned to be a dashboard in place by summer 2022 so that PCNs can monitor how they're doing compared to maximum performance in each area. I think it's going to be really important that the managers at the PCN have access to this and do monitor it closely, because as we've seen, there's quite a lot of funding attached to this, and there may be small changes that can be made throughout the year to try and maximise the performance from this. In a similar way to as happens within individual practices when they're reviewing their QOF performance. So I think this is something that the PCN really need to try and get a handle on and look at what the performance is throughout the year. So in terms of how the points are assessed, there are a few different methods. So some points are measured on a qualitative basis. So that means that you have either done something or you haven't. So it's a bit of a tick box exercise. You need to have ticked all the boxes within a certain area to qualify for the points in that particular area. There are quantitative measures as well. That's where you achieve a certain percentage of coverage for the whole population. So it may be, for example, that you have to have a certain percentage vaccinated for flu, or it can be an improvement compared to your baseline performance. So you may have a measure of, for example, blood pressure, and you have to get an improved measure for those patients within the basis period. Or it may be a composite measure, which is basically the best of both of those performances. There is the potential to exclude some patients before the calculations are run, and there are detailed rules within that 97-page document on how to do that. And there are exceptions, so called personalised care adjustments. So for example, if it's not clinically appropriate to treat a patient for a certain area, they can be excluded. But again, details are within the document on how to do that. And there will be adjustments for prevalence and list size, the same as happens currently within QOF. So quite a new area really for PCNs to get to grip with, and quite a lot of funding available to that. So you'll see from the section I've covered really that GMS and PMS practices are seeing minimal increases. in their funding, and all the new funding is being diverted through the PCNs. I think that will continue going forward. So if there are any practices that are looking at coming out of the PCNs, I think they do need to consider that going forwards.